picking up. It will take 1 minute.
Okay, fine, sir.
Yes, go ahead, madam. You're on.
Okay, sir, fine, thank you. So last time we discussed about many questions in the same topic, that is the abortion, and we discussed even some of the MCQs, as I have told. So today I'll be continuing with the same topics with the more MCQs. Okay, so I'll start with this question. Probably last time we ended up with McDonald's stitch and the treatment for cervical incompetence. Now, this question, number 22, a 8-year-old female with a history of 8 weeks of amenorrhea. Students, I would like to remind that I want you all to be interactive. The questions will be open to everyone, and I want you all to answer as many as possible and as quickly as possible. And it will be more interactive. And if there's any doubt regarding anything, please be free to ask me at any given time. And we can always stay back and discuss more aspects of the same question if anybody is having any doubt. So we'll just begin with this. Maybe it could be repeating 2-3 questions, but it's okay. Meanwhile, many people can join. So a 28-year-old female with a history of 8 weeks amenorrhea complains of vaginal bleeding and lower abdominal pain. On ultrasonography examination, there is gestational sac, but with absent fetal parts. The diagnosis is an ectopic pregnancy, an incarcerated abortion, threatened abortion, or a corpus luteum cyst. What is the answer for this question? Quickly, if anybody can tell me. Yes, students? See here, what are the features, what I mentioned? She has 8 weeks of amenorrhea, and she has vaginal bleeding and lower abdominal pain. So these two indicate that there is some abnormality in her pregnancy. The vaginal bleeding as well as the lower abdominal pain indicate that there is an abnormal feature in the pregnancy of whatever 8 weeks of amenorrhea. So whenever there is a PV bleeding in the first trimester of pregnancy, the first thing or the most common problem which should come to your mind is an abortion. So again, in the abortion, as we discussed earlier, there are different kinds of clinical varieties, and based on the clinical presentation and ultrasonography, we have to diagnose which kind or what kind of abortion it is. So, but then, of course, as I told, when there is a vaginal bleeding in the first trimester, always think of the abortion as the first cause or the diagnosis, and the other two important causes being ectopic pregnancy and hereditary form mole. Okay. So first thing is, of course, as I discussed, abortion. Now, what are the other things in this question? On ultrasonographic examination, there is a gestational sac, but with an absent fetal parts. Okay. See, remember we discussed earlier that the gestational age of the pregnancy should correspond to certain features which should be seen on the ultrasonography. For example, at 5 weeks of gestation, I'm talking about a transvaginal sonography here. At 5 weeks of gestation, we should be able to see a gestational sac. At 6 weeks, we should be able to see a yolk sac as well as a fetal pole, and also sometimes cardiac activity at 6 to 7 weeks of gestation. So in this case, on ultrasonography, though the pregnancy, according to her history, is 8 weeks, what they're able to see is only a gestational sac. Okay, so depending on these features, what is the likely answer amongst these? Let us go one by one. A, is it ectopic pregnancy? Anybody? Is there any feature of ectopic pregnancy in the statement or in the question above?
No, ma'am.
No, is it not? So it's absolutely no indication that it's a ectopic pregnancy, because in an ectopic pregnancy, what is an important feature is the gestational sac is absent in the intrauterine cavity. The intrauterine cavity will not have any gestational sac, and a complex, if it's an unruptured ectopic, then you can still see a gestational sac outside the intrauterine cavity. Whereas if it's a ruptured or a complex one, then you will be able to see some adnexal mass in the some complex mass in the adnexa. So those features have not been mentioned here, and therefore it's not at all an ectopic pregnancy according to the statement. Now, incarcerated abortion. What do you mean by incarcerated abortion? Incarcerated abortion means it's like, you know, something like which has stopped growing, or it has had a stunted growth. So in this case here, as they have mentioned, it's 8 weeks of pregnancy and they are able to see a gestational sac, but there is no fetal parts. So there has been some stunting of the progress in the pregnancy, is it not? There has been some hindrance to the development of the normal pregnancy, whereby an fetal pole has to be appearing in a normal gestation by about 6 weeks itself. So incarcerated abortion, or it can also be called an what do you call an embryonic pregnancy, because the fetal parts are absent. So normally in the, you know, textbook terminology, we call it as an embryonic pregnancy or an embryonic abortion. It's also called as a blighted ovum. So whenever there is a gestational sac is seen, but you cannot see the fetal pole, such a situation is called as a blighted ovum, or it's also called as an embryonic or abembryonic pregnancy. And here, if you go by incarcerated abortion, this could be an option, because it means that the pregnancy is stunted, or there has been a what you call a stoppage of the growth of the progress of the pregnancy. So this could be an option. Now coming to other two options, threatened abortion. Can it be threatened abortion? When do you call it as a threatened abortion, students? Anybody? We did discuss about all this in the previous classes. Can anybody explain what are the features in threatened abortion? Yes?
Ma'am, it has not gone to the stage where it is not reversible. Like it has not reached that stage.
Right. So the patient has, you know, a normal pregnancy, but the features or the process of abortion has started, and it's not yet gone to a stage where it cannot be reversible. In the sense, if you treat her with some medications and good amount of conservative management like rest and all that, the pregnancy is still viable and it can be continued. So what are the features on the ultrasonography in a threatened abortion is that it should have a normal pregnancy finding, in the sense it should have a gestational sac, it should have a fetal pole, it should also have a yolk sac. Okay, and in the fetal pole the cardia should be present. Okay, the heart rate should be, we should be able to count in the heart rate, and the cardia should be present, the fetus should be live. Okay, so this is the most important feature in threatened abortion. And sometimes because of the bleeding or any other abnormality like a subchorionic bleed, or you know, a low-lying kind of a placental feature, so these could be seen in threatened abortion. Okay, any other abnormality which could lead to a slight bleeding with which the patient presents, but it should have a normal gestational sac, a fetal pole, as well as a yolk sac. Now, in this case here, what they've mentioned is that the fetal parts are absent. So, when the fetal parts is absent, there is no question of threatened abortion coming to your picture, is it not? So, it's clear cut. It's not a threatened abortion. Do you all agree with me? There's no confusion here, is it not?
Yes, ma'am.
Right. So, of course, the last option, corpus luteum cyst, is absolutely not relevant here in this case, because they're asking for the diagnosis and the cause for the vaginal bleeding. I mean, the cause for, you know, the problems here associated, that is gestational sac is absent in fetal parts. Gestational sac is present and absent fetal parts. So, corpus luteum cyst is nowhere relevant to this particular question. So, the answer here would be B, that is incarcerated abortion. So make sure you know what is ectopic pregnancy, and make sure you know what is threatened abortion. Automatically, once you exclude these two answers, and this of course is irrelevant, you will be surely, you know, finding getting into the right answer in such cases. Okay. Now go to the next question. Antiprogesterone compound RU486 is effective for inducing abortion if the duration of the pregnancy is 63 days, 72 days, 88 days, or 120 days. That means what gestation age is legally advised, where the mifepristone, which is also called as RU486, it is an antiprogesterone. It is used for medical termination of pregnancy, that is in the medical therapy. So what is the recommended age, gestational age, until which you can successfully give this mifepristone for a higher chance
Option
of
A, ma'am.
complete abortion? Yes, answer A is correct. So the recommended gestational age until which you can give mifepristone with a high success rates is 63 days. Beyond that, they have found that there is a very high chances of incomplete abortion, or the process doesn't get in set in at all. So that's why the RU486 of mifepristone is to be recommended to be given until 63 days of gestation. Clear? Next, all of the following drugs have been used for medical abortion except mifepristone, misoprostol, methotrexate, or atosiban. This is an easy question. I think we discussed last time. Come on.
Fourth option.
Fourth, that is the
Atosiban.
atosiban is not used, whereas all of the three are used. Is it not? Yes. Next one. In extraembryonic second trimester medical legal termination of pregnancy, which of the following is used? Ethacridine lactate, prostaglandin, hypertonic saline, or glucose?
The first option.
First, of course, it's well known to all of you and is the most commonly used option. That is extra amniotic instillation of ethacridine lactate, of course. Then any other drug can also be used in this one. See, remember, it's a PGI question, and more than one option answers will be right in such examination. So, which
Hypertonic
are
saline.
hypertonic saline, actually we do not use extra amniotic, but prostaglandin can be used. Okay, prostaglandin, like misoprostol, what we do is we mix it with saline and then instill into the extra amniotic cavity. So the answer here is A and B, that is ethacridine lactate and prostaglandin can be used for the MTPs in the second trimester in the form of extra amniotic instillation of the fluid. Okay. Next, according to MTP Act, two doctors' opinion is required when pregnancy is 10 weeks, 6 weeks, more than 12 weeks, more than 20 weeks, or 8 weeks. Yes?
More than 20 weeks.
More than, sorry?
20 weeks, ma'am. Option D.
More than 20 weeks, you cannot do MTP at all. Is it not?
Okay, more than
Until
12.
when, yeah,
More than
what is the legal age? What is the legal age at which MTP is allowed in our country according to the MTP Act? It is only up till 20 weeks, remember. Okay.
20.
And the answer for this question is actually C, that is more than 12 weeks. So whenever the pregnancy is more than 12 weeks, we require a opinion of two doctors. Though two doctors might not be present for the whole procedure, but before initiation of the procedure, we have to document an opinion of two gynecologists or two doctors who are eligible to perform an MTP. It cannot be any other two doctors, but those two doctors should be gynecologists or a registered medical practitioner who is, authorized to do a medical termination of pregnancy. So we need two opinion of doctors, and it has to be documented in the case sheet. Okay, and then you start the process of abortion. So remember, it is more than 12 weeks, and less than 12 weeks, you need not have a second doctor's opinion. You can straight away go ahead with the procedure, whatever you are planning for. Okay, remember this one. For medical termination of pregnancy, consent should be obtained from the male partner, the male as well as the female partner. The female partner, or consent is not required. Anyone?
Option D.
Female partner.
Option C, the female partner. Female.
Yeah, option C, the female partner is the right answer. Remember, we just require the consent of the woman who is undergoing the medical termination. We do not need the consent of the male.
Hold on, I'll talk to madam. Huh? I'll talk to madam. Hold on a minute. Madam will come back. Hold on a 1 minute.
Sorry, can you all hear me now? There was some disconnection, I guess.
Yes, ma'am.
Okay. Are you all seeing the PPT?
No, ma'am.
No, ma'am.
Okay, just a moment. Give me some time. Yes, sir. I'll have to again go back and I think.
Hello?
Hello?
Yes, madam. Present now.
Yes, sir. Now you're able to see?
Yes, madam. Yes, madam. Right.
Okay, sir.
Yes,
Thank you
madam.
so much. Yeah. So I think we finished this question, right?
Yes, ma'am.
So we'll go to the next question. Now, mifepristone is not used in threatened abortion, fibroid of the uterus, ectopic pregnancy, and molar pregnancy. Remember, mifepristone is RU486. It is also called as the property is antiprogestin. So, anybody with the right answer here? Mifepristone is not used. Remember, rightly read the question. Not used in. So, what is the answer?
Fibroid.
Fibroid. Anybody else?
Threatened abortion.
Threatened abortion. Yeah, that's the right answer actually. Can you tell me why is it so?
Because it's still not aborted, ma'am. It's just started to abortion. So we can't
See,
give
right.
it under.
So in a threatened abortion, you want to save the pregnancy, is it not? So when you want to save the pregnancy, logically, you need to give some medication which is going to kind of sustain the pregnancy. So to sustain the pregnancy, you need to give hormones, mainly early pregnancy. It is, the human chorionic gonadotropin, HCG, or some progesterone. You give a natural micronized progesterones to sustain the pregnancy, is it not? So threatened abortion, actually you want to save the pregnancy and therefore you need to give supportive hormones and not a mifepristone, which is antiprogestogen actually, is it not? So mifepristone is an antiprogestin and you give it in cases where you want to kind of dismantle the pregnancy, something like that. So in conditions like MTP, of course, you use mifepristone as a combination with the misoprostol. You use it as a combination for medical termination of pregnancy in the early days, that is up till 63 days, as we discussed. So since it has a antiprogesterone property, it is also used in ectopic pregnancy and in molar pregnancy. Remember, in ectopic pregnancy, especially unruptured ectopic pregnancies which have been diagnosed very early, and you can still, when the patient is clinically stable, then you can still go for an expectant management where you give drugs to destroy that pregnancy in the ectopic site itself. So it mainly the mainstay of this treatment is giving a drug which is toxic to the cytotrophoblastic tissues, like the methotrexate is the most commonly used drug in ectopic pregnancy. But mifepristone can also be used since it has an antiprogesterone activity. It kind of dismantles or disengages the pregnancy and stops the growth of the pregnancy. Therefore, it can be used in ectopic pregnancy. Similarly, in molar pregnancy as well, especially when you have molar pregnancy, the mainstay of treatment, of course, is suction evacuation, where you need to evacuate all the trophoblastic or hydatidiform moles present within the uterine cavity. But sometimes, because the uterus is very soft and there are very high chances of perforation in the first sitting, we need to do these evacuation of the molar pregnancy in multiple sittings, sometimes second or third time as well. So in those cases, when there is even a small amount of the tissue leaving behind, is okay, and then you treat the patient conservatively with good follow-up, where you give her either methotrexate or again mifepristone can be given, so that the very small retained products of the conception in case of post-molar evacuation pregnancy can be treated expectantly. Okay, so it can be given in these two conditions. Another important indication of late, mifepristone, remember, it's used in fibroid uterus, especially where there are multiple fibroid uteruses, and the patient is young, she wants to conserve her uterus, and before trying out with the infertility treatments, or if the patient is old enough and she is still waiting for her turn for hysterectomy, or there are comorbidities in which she is unable to go ahead with the surgical options for fibroid uterus, then mifepristone is used in a therapy, in long-term therapy, 3 to 6 months, which helps in reduction in the size of the fibroids. So remember, mifepristone is one of the drugs of choice for treating the fibroids conservatively, and of course in ectopic, molar pregnancy and MTPs, and definitely not in threatened abortion, as I discussed. So the answer for this question is A, that is threatened abortion. Clear with all of you? I hope you people are there, because if you don't respond to me, I'm not sure if I'm connected to you. Students? Okay, fine. So next question. Blighted
Yes,
ovum
ma'am.
is synaptic
Yes, ma'am.
knobs, avascular villi, intervillous hemorrhage, or none of the above? It's an easy one. What do you see in the blighted ovum in the scan or in the ultrasonography? Blighted ovum.
Parts are not seen.
Yeah.
Fetal parts are not seen, but the gestational sac with fetal pole may or may not be
No,
present.
fetal pole is always absent in blighted ovum. Remember, the gestational sac is the one which is only seen. What is may or may not be present is the yolk sac. Okay, so don't confuse there. So gestational sac is present. It is either empty without a yolk sac or the fetal pole. Sometimes the yolk sac might be seen, but later on it does not develop, and the fetal pole is absolutely not seen in case of blighted ovum. So the answer for this will be avascular villi. Okay, so it's actually where the chorionic villi do not develop and the fetal pole does not develop at all. So that's why it is a avascular villi. Okay, there is no intervillous hemorrhage or synaptic knobs. When there is no villi, there is no question of intervillous hemorrhage. Okay, remember. So the answer for this question is B, that is avascular villi. I'll just take you back quickly to that picture where I have shown the blighted ovum, so that it gets registered in your minds. What do you mean by blighted ovum? See, normally when we discussed earlier, when we discussed the gestational sac should be seen by about 5 weeks of gestational age by the transvaginal sonography, and the fetal pole should be seen by 5 to 6 weeks, and the cardiac activity to be seen by again 6 to 7 weeks. Okay, so here you can compare and see at 5 weeks only the gestational sac is seen. But by the next week, that is between 5.5 to 6 weeks, you should be able to see a small yolk sac. This is gestational sac and a small yolk sac. Subsequently, by 5.5 to 6.5 weeks, you should be able to see the gestational sac, the yolk sac, as well as a small fetal pole here. And then by 6.5 to 7 weeks, you should be able to clearly make out the gestational sac with the yolk sac and a proper fetal pole. You can also measure the crown rump length. So this is by 7 weeks. So with these normal events happening, and in an abnormal pregnancy, if the patient is coming to you with 6 to 7 weeks of pregnancy, and at that time you are still not able to see the fetal pole, then that makes an abnormal observation and an abnormal pregnancy. And that is the case where you see an empty gestational sac. The sac will be corresponding to 6 to 7 weeks gestation. When you measure the sac diameter, it will be corresponding to 6 weeks to 7 weeks pregnancy, but you will not be able to see a fetal pole inside. So that is the time when you diagnose it's an embryonic or a blighted ovum. So is it clear to all of you? What do you mean by blighted ovum? So when the fetal tissue is absent, that means even the villi or the chorionic tissue also will be absent. So that's why the answer or the option for that particular question is that avascular villi. Okay. Now, the most life-threatening complications of septic abortion includes peritonitis, renal failure, respiratory distress syndrome, or septicemia, which is kind of, the last event which would eventually lead to death in case of a septic abortion.
Oh, renal failure it should be then.
Renal failure. Anybody with any other answer?
It can be septicemia also.
Septicemia, yes. See, all these are features of the septic abortion. Okay. So remember, initially there is peritonitis. Peritonitis is a local infection, is it not? So the infection is just restricted to just the local organs, that is the pelvic organs, and even it might extend into the abdominal cavity, leading to peritonitis. So this is still in the local stage of infection, peritonitis. Subsequently, the patient ends up with the septicemia, okay, where the infection or the toxic inflammatory markers because of this infection will enter into the bloodstream, leading to septicemia, right? Subsequently, because of the septicemia, and the patient ends up with a hypotension, or she ends up in septicemic shock because of hyperpermeability of the blood vessels, the seepage of the intravascular fluid that leads to hypotension and subsequently hypoperfusion of the kidneys and leading to renal failure. Is it not? In this state, still the patient can be managed effectively by going ahead with dialysis, giving her, of course, the supportive treatment with antibiotics and so many other supportive therapies like inotropes also can be started, where the hypertension can be corrected and the renal perfusion can be improved and the renal urine output can be improved. But the last stage of the disease, where the patient ends up with, one is respiratory distress as well as multi-organ dysfunction, is the last stage of the disease where the patient is very critical, and usually she or he succumbs to succumbs and results eventually in the death. So if you go into the series of events of septic abortion and chronologically, if you see, the answer for this question would be C, actually, that is respiratory distress syndrome. That's the last event amongst these options which they have given, which could eventually lead to death of the patient. See, the question here is most life-threatening. Okay, so these three things can still be treated, as I told. But once the patient is in respiratory distress, it indicates multi-organ failure and hypoventilation, hypoxemia, or even there could be acidosis, metabolic-related problems, and resulting in respiratory distress. And these together will eventually lead to death if not treated aggressively. So the answer for this question would be C. Is it clear to all of you?
Yes, ma'am.
Yeah. So next one, the method most suitable for MTP in 3rd month of pregnancy is dilatation and curettage, extra amniotic reticular installation, C, hysterectomy, D, suction evacuation. Yes, this is a very easy question. 3rd month of pregnancy means it's about. Yes, the answer for this question is, of course, suction evacuation. So remember, 3rd week of pregnancy means it will be around 10 to 12 weeks or 9 to 12 weeks. Okay, so 9 to 12 weeks. What is the most important method is actually a surgical method. So it could either be a DNC or a suction evacuation. Right, so definitely not hysterectomy and definitely not extra amniotic ethically lactate. This is only used in 2nd trimester, is it not? So 3rd month means the patient is still in 1st trimester. Now the medical methods can be recommended to be used only up till 63 days, that is about 9 weeks. Until 9 weeks, we can still use the medical methods for MTP. Beyond that, it is only surgical methods, that is DNC or suction evacuation. And amongst these two, which is the most safer and most widely used method nowadays, it's the suction evacuation. Okay, so here in suction evacuation, it is preferred over dilatation and curettage because the trauma to the endometrium is lesser and the procedure is more complete, and the chances of incomplete abortion or retained products of conception is also lesser because we are using a mechanical or electrical suctioning here, so that all the products are evenly sucked out and there is no chances of anything being left behind. And the trauma also, or the perforation or the any other complications are also lesser with suction evacuation. So that's why that is the most preferred method and the most followed method nowadays, rather than dilatation and curettage. Right? Clear to all of you? Next one, pregnancy which continues following threatened abortion is likely to have increased incidence of preterm labor, fetal malformation, IUGR, all of the above.
All of the above.
All of the above is the right answer, correct. So any pregnancy which has been, presented with a threatened abortion in the early pregnancy, always counsel the patient that she might have the chances of, if the pregnancy continues, then she will definitely be at the risk of preterm labor, sometimes fetal malformations, and even IUGR. So all these are possibilities in such cases. So the answer is D, all of the above. Next one, the best method of evaluation of a missed abortion in uterus of more than 12 weeks is, evacuation. It is not evaluation. The best method of evacuation of a missed abortion in uterus of more than 12 weeks is oxytocin infusion, B, intramuscular prostaglandin, that is 15-methyl-PGF2 alpha, prostaglandin, even vaginal misoprostol, followed by evaluation of the uterus, evacuation of the uterus, or suction evacuation. Yes. So more than 12 weeks it's in the 2nd trimester, is it not? So amongst these options, which is the most appropriate answer for 2nd trimester?
First.
See, oxytocin infusion
Option
is.
C, ma'am.
Yeah, option C is the right answer actually. Just like to explain why. Oxytocin infusions, it takes a long time. Okay, it is something like induction of labor, and oxytocin may not alone be sufficient, or it's not very ideal to actually incite the process of MTP or abortion in case of 2nd trimester. It acts better in the 3rd trimester. So oxytocin infusion we do not use for as a method of MTP, especially in 2nd trimester. Now, intramuscular prostaglandin is again having a lot of disadvantages. Always remember, IM prostaglandin, you have to inject this every 2 hourly, 3 hourly. to the patient so that she responds to your induction and subsequent abortion occurs. See here, the patient will have to undertake a lot of maybe 5 to 7 doses of intramuscular prostaglandin injection. And remember, prostaglandin injection has a lot of side effects, especially GI side effects like vomiting, loose motions. So most of the patients end up with these side effects, and the method is prolonged, and there will be a lot of debilitating issues with the patients. So intramuscular prostaglandin, though it was tried earlier, it is actually not a convenient procedure for MTP, especially in second trimester. Now this option, as we discussed and said, right, is the answer for this question. Remember what we do here is the even gel vaginal prostaglandin even, that is nothing but misoprostol, is kind of used to prime the cervix in such situations. So once we prime the cervix with misoprostol, we use about 400 to 400 micrograms of misoprostol to prime the cervix. Once the cervix primes, and it will be kind of an induction only, and the uterus begins to contract, and subsequently once the cervix opens and almost the products are expelled in the process of expulsion, the os is open, and then when we do an evacuation in such a situation, it's a very easy, and the procedure is usually very complete and successful. So this is the best combination for medical termination of pregnancy in second trimester, where we prime the cervix first by the vaginal misoprostol, and then once these os opens and kind of the products are detached from the uterine walls and kind of located in the lower part of the uterus, it becomes easy for us to dilate the cervix and evacuate the products of conception with the help of a suction evacuation. Right? So this is the ideal method. Not only in the pregnancy after 12 weeks, even before 12 weeks, as I discussed, between 9 to 12 weeks also, this is an ideal procedure, where remember in the missed abortion, the os is closed there. Okay, the patient has hardly any symptoms. She might just present with a kind of a brownish discharge per vaginum, and on ultrasonography you diagnose that the fetal cardiac activity is absent. So here the os is closed. So in order to prime the cervix, this is the best method. That is, you do a vaginal misoprostol installation first, prime the cervix so that the os gets dilated, opens, and then you do the evacuation of the uterus. Clear to all of you?
Yes, ma'am.
Okay, next question. Suction evacuation can be done up to 6 weeks, 10 weeks, 15 weeks, 18 weeks.
15 weeks.
Anybody?
15 weeks.
15 weeks is the right answer. Yes, it can be done up till 15 weeks of pregnancy, right? Next one. A para 2 plus 1 female comes with amenorrhea of 5 weeks. Her UPT is positive. On ultrasonography, gestational and yolk sac are seen in the uterus. No fetal pole is visible. No fetal cardiac activity is seen. CRL is 8 mm and mean sac diameter is equal to 28 mm. What is the next best step? A. Advise MTP as it is non-viable pregnancy. High probability of non-viable pregnancy, but still repeat scan after 7 days to confirm. Can be ectopic pregnancy, give methotrexate. High probability of viable pregnancy, repeat scan after 7 days.
Second option.
Second option,
But still
that
repeat
is
scan.
high probability of a non-viable pregnancy, yes, but still you should repeat the scan after 7 days to confirm. So that's the right answer. That's correct. Because you can see she is giving history of just 5 weeks of her pregnancy. UPT is positive. And at 5 weeks, what you're able to see is still okay, in the sense there is a gestational sac and yolk sac. Okay. So fetal pole not being seen at 5 weeks is still okay. Sometimes there could be delayed conception. So by just one scan at one event, you cannot label this as a abnormal pregnancy, as rightly said, though there is a probability of a non-viable pregnancy being, but you should always confirm by a second scan, that is after minimum of 7 days or a week's time. You need to repeat the scan and confirm the same. So the answer for this question, the right one is B, of course. So here, as I said, once until you confirm, you cannot advise MTP. So this option is ruled out. And it can't be ectopic pregnancy because they're able to see a gestation sac and yolk sac is seen in the uterus. So it can't be an ectopic pregnancy. And here, high probability of viable pregnancy, repeat the scan after 7 days. Here, because important thing what you have to remember is CRL is 8 mm. Okay. And the mean sac diameter is 28 mm. By this time, it should actually be corresponding to the gestational age of about 6 to 7 weeks of pregnancy. So when you go by the CRL measurements and the gestational age, the table, and also the mean sac diameter and the gestational age at which the pregnancy should be there. Remember, in the subsequent slides, I'll be able to show you the chart. The mean sac diameter at 28 mm should actually be a pregnancy corresponding to 6 to 7 weeks of pregnancy, but here it's only 5 weeks of pregnancy. So that's why the probability of a non-viable pregnancy is higher, and therefore this answer will be the right answer for this question. Is it clear to all of you? Any doubts in this?
No, ma'am.
Fine. Now, next question. The figure shows Carmen cannula. The number of cannula corresponds to diameter of the cannula in mm, diameter of cannula in centimeters, surface area of cannula, or the length of the cannula. This is an easy one. Come on. First one, correct. So it corresponds to the diameter. It's the whatever the number is written on the cannulae, usually it's the diameter of the outer diameter of the cannulae. So most of the times what we use is 7 mm, 8 mm, 9 mm, depending upon the weeks of gestation. So whatever is written on the number is actually the the diameter of the cannula in mm. Correct. Now, a few words about Carmen cannula. It's a long tubular structure made of plastic or metal. It's rigid or flexible. Sizes range from 4 to 12 mm. Parts, it contains a distal end, which is with the double whistle at the terminal end. Proximal end is fixed to a syringe. It is superior. Overhanging edge acts as a curette as well. The number of cannula corresponds to the diameter of the cannula in millimeters. And a plastic cannula is preferred because it is less traumatic, transparent, and disposable. So this here you can see it's the tip kind of it's sharp, and the tip is blunt here, and it has an opening here as well as here, which act as a curette as well. So as they mentioned, the diameter will be in mm. So this is the Carmen cannula. The other end will have a syringe, or it can be attached to the suction tube as well. Now, next question. Identify the instrument. Sponge holding forceps, Haywood Smith's Ohm forceps, Alice tissue forceps, or Lane's tissue forceps?
Ohm forceps. Second option. Smith's Ohm forceps.
Yeah, Ohm forceps is the right answer here. So how would you differentiate? Most importantly, you remember, of course, you will be able to identify Alice and the Lane's tissue forceps. So you will get confused between the sponge holding and the Ohm forceps. Okay, so remember, in the sponge holding forceps, it's usually fenestrated. Both the ends are fenestrated. You have a big round hole, at the ends. So kind of it holds the sponge. So this is how a sponge holder forceps actually looks. Whereas an Ohm forceps, remember, it has a cup-shaped, ends. The ends are like a scoop, and there'll be fenestrae. Long fenestrae are there in this scoop, or long slits are there in this scoop. So both the sides it will be there. So this is actually the Ohm forceps, and the tip will be blunt. Okay, so this is how you can differentiate between a sponge holder and an Ohm forceps. So another important thing, how will you differentiate, is that the Ohm forceps does not have a lock, whereas a sponge holder has a lock. And there are fenestrae or serrations on the inner surface of the the edge, the round edges. When you see here, there is a big hole, as I mentioned. The inner surface of the sponge holder will have a striae or serrations like this, whereas differentiation point. So are you all there with me? Students?
Yes, ma'am.
Fine. I hope there is no disconnection. Now, next. Unviable pregnancy and viable intrauterine pregnancy. 5 and 20, 10 or 20, 5 and 50, and 10 50. Which is the right answer here? Anybody? This is a theoretical question. If you have read, you'll be able to answer. If not, I'll give the answer to you. The answer is A actually. So a non-viable pregnancy will have progesterone levels as low as 5 nanograms, and a normal viable pregnancy, intrauterine pregnancy, will have the progesterone levels between at 20 nanograms per ml. Okay, so this is the answer for this question. Next one. Best method for MTP in second trimester abortion is oxytocin, prostaglandin, ethacrydil, or hypertonic saline.
Prostaglandin.
Prostaglandin or even ethacrydil actually. So both can be the answers for this question. This is what we commonly use nowadays. In fact, sometimes we even use a combination of ethacrydil plus prostaglandin. But remember, both can be the right answer for this question. Okay. So these are the questions from previous year question papers, and what we discussed were all previous year question papers and repeated questions. Now I'm going to come up with few questions from different set of books, and they are more relevant clinically, and this is what is the pattern of questions being asked in the exams nowadays. So I hope this will help you all as well. It's already 8 o'clock, so we'll just do a few questions in this section and continue with the remaining questions in the next class. Okay, so beginning with the first question, which of the following sonogram findings is consistent with the American College of Obstetricians and Gynecologists definition of early pregnancy loss? An embryonic pregnancy, a crown rump length of 7 mm with no cardiac motion, a fetus measuring 13 weeks gestation with no cardiac motion, all of the above. Remember, these ACOG is one of very reputed associations in the obstetric and gynecology, and they do a lot of research and they have a lot of guidelines, especially in gynec practices, and a lot of countries follow this American guidelines of the American College of Obstetricians and Gynecologists. So there could be questions related to this, and even these guidelines have been mentioning in the standard textbooks as well. So you should be knowing few of these important guidelines. So one such question regarding the abortion is this one. What according to ACOG is definition for early pregnancy loss? Anybody with the answer?
Last option.
Last one.
All of the above.
No, it can be. See, it's early pregnancy loss. See, fetus measuring 13 weeks is not early pregnancy. Okay, so early pregnancy loss always should be in the first trimester. So option C is ruled out here, is it not?
Yes, ma'am. Yes, ma'am. Sorry.
Yeah, so don't get confused here. So it should either be A or B. That is an embryonic pregnancy, or a second option, that is when the CRL is 7 mm and no cardiac motion. So anybody who know when the cardiac activity should be present in the fetus corresponding to what crown rump length? Anybody? Right, it's actually both can be the answers according to the guidelines. So an embryonic pregnancy, of course, is an abnormal pregnancy, and it shows that there is early pregnancy loss. An embryonic pregnancy is nothing but blighted ovum, the one which we discussed earlier, where there is only gestational sac seen and there is no fetal pole. Okay, so here the second option, that is a crown rump length of 7 mm with no cardiac motion, is also a definition for early pregnancy loss. a Society of Radiologists in Ultrasound, and this has been endorsed by the ACOG as well. These are few of the diagnostic criteria for pregnancy failure. Remember, the CRL of 7 mm or more with no heartbeat, when the mean sac diameter of 25 mm or greater and no embryo, when there is an absence of embryo with heartbeat 2 weeks or more after a scan that showed a gestational sac without a yolk sac, an absence of embryo with heartbeat 11 days or more after a scan that showed a gestational sac with yolk sac. So these are the features of early pregnancy failure, and these have been the criteria put up by the Society of Radiologists and endorsed by the ACOG. So these are the important points to remember. These are again in elaborate things, so this is not necessary for you all, but it's important that you remember these criteria to diagnose that there is a early pregnancy failure or an abnormal early pregnancy. So it's clear with you all? So we'll go ahead with the next one. What percent of spontaneous abortions occur within the first 12 weeks of gestation? It's 60%, 70%, 80%, or 90%. It's a very easy one. So amongst the spontaneous abortions, which is the what is the percentage occurring within 12 weeks of gestation or within the first trimester? Are you all there with me, students? I hope there is no disconnection.
Yes, sir.
Yeah, so please answer quickly. We'll move on so that we can cover up more questions. We discussed about all these in the previous classes, is it not? Anybody?
Second, I'm not sure. Second.
The answer is C, 80%. Okay, so 80% of the abortions occur within the first trimester of pregnancy. Remember. Next, a 22-year-old Gravida 1 para-0 presents for a follow-up visit after receiving care for a spontaneous abortion at 8-week gestation. She has many questions regarding the possible cause of her miscarriage and the risk of recurrence. You counsel her that approximately what percentage of pregnancies will end in miscarriage? 3 to 5%, 5 to 10%, 10 to 25%, or 40%. So these are all clinical scenarios, what they are, giving it to you. So it's actually when a patient with a abortion coming to you, and how are you going to counsel or talk to her about her apprehensions regarding why she had the miscarriage, whether it's going to be recurrent. All these are practical questions or case scenarios which they might ask. And of course, they will all be related to some theoretical figure or a concept which you need to remember. Yes, anybody with the answer? What is the percentage or a normal in the normal population? What is the percentage of miscarriages? Anybody? It's actually C, 10 to 25%. Okay.
Ma'am, I have a doubt, ma'am. Regarding this one, shouldn't it be variable with the different factors? Like for genetic, it will be less, but for immunity, if suppose she has autoimmune disorders like anti-lipid and autoimmune disorders, it will be around 10 to 15. But if it is genetic, like suppose carriers, suppose the fetus is congenital anomaly, so it will be little less. I guess I'm not sure. And in cervical incompetence, it might be up to like 20 to 30% there. So how can we?
Fine. That's what. See, here it is just the general incidence before you evaluate. We don't know at 8 weeks of gestation what was the cause. 8 weeks, most of the times it is again falling in first trimester. Most of the times it is because of some chromosomal abnormality or a genetic abnormality. Okay, so what they've asked here is just a general scenario where even before identifying what was the cause for her abortion, how will you counsel her? Okay, they have not given you any specific reason as to her abortion and then asking as to what is the incidence. So in the general population, when you go go with the books with the incidence of miscarriage in a general population, not in a high risk population. So a high risk population is a population something in which there is a comorbidity associated with abortion, as in any endocrinological problems like a diabetic. In patients of diabetes, the rate of miscarriage will be higher, or in patients with hypothyroidism, the rate of miscarriage will be higher, or if the patients are, as you told, any genetic abnormality, or the parents are having an abnormal karyotype, again, of course, the incidence of the miscarriage will be higher in such high risk populations. Right, but as a general sporadic mutation, if you take into consideration, then the incidence will be just 10 to 25% in a general population, and that is what you actually put it up to the patients when they're coming to you for the first time abortions. Remember, here it's just the primea gravida. Gravida 1 is a primea gravida with her first abortion, so you will not categorize her into a high risk population for abortion. She falls into a general population category. Right. So if it were to be a recurrent abortion where she's like third gravida with a previous 2 history of abortions, then she falls into high risk or one of the causes for recurrent abortions, and then you will actually be giving her the the risk involved in miscarriages in such high risk populations. So is it clear? Hope you have some understanding regarding this, whatever I told.
Yes, ma'am, understood.
Okay, so this is a general question. Remember, she is just primary with 1 abortion. So in such cases, you will just give them, what is an average miscarriage rate for the general population rather than the high risk population. Okay. So the answer here is C, that is 10 to 25%. Next. For the patient in question 18.3, that is the last question, you also counsel her regarding the rate of aneuploidy in first trimester miscarriages. Now here they're coming to your point of view. Okay. Now what is the approximate rate of aneuploidy in pregnancies that end in a clinical apparent first trimester spontaneous abortion? 10%, 20%, 33%, 50%. Now here you should be able to tell her if at all the cause for her abortion, that is the first trimester abortion, what she has had is any aneuploidy, which is again the most common cause of first trimester abortions. What is the rate? Anybody with this answer?
It's in a range of 13 to 15. I'm not sure like which percent it falls.
No, it's very high, not like 13 to 15. Its answer is 50% actually. So 50% of the first trimester abortions, the most common cause is aneuploidy. Remember, right? Next one. A patient presents for her first obstetrical visit at 8 weeks gestation by last menstrual period with complaints of vaginal spotting. On examination, the cervical os is closed without active bleeding. A sonogram is performed as shown below with cardiac motion noted. What is the correct diagnosis? Missed abortion, ectopic pregnancy, incomplete abortion, or threatened abortion? Anybody with this answer? See, they've given a clinical scenario here, 8 weeks. She's just having vaginal spotting, os closed. And the cardiac activity is present. You can see the cardiac activity here.
Okay, it should
so
be
it fits into which one?
Abortion. Threatened abortion.
Threatened abortion, is it not? It's very much clear. It can't be missed abortion, because in missed abortion, what is the important feature you should be able to identify in missed abortion? On scan, the cardiac activity is absent. Is it not in missed abortion? The fetal demise will be there in case of missed abortion. So the cardiac activity is absent in missed abortion. Whereas in this case, they have mentioned that the cardiac motion is noted. And here also you can see in the M motion, the cardiac activity is seen here. They're measuring the heart rate. Okay. So this is not the option. Of course, ectopic pregnancy is absolutely irrelevant here, where there is a gestation sac within the uterus and they're able to see the gestation sac and the fetal pole and all that. Incomplete abortion is not an option because as they have mentioned, the os is closed and you can see the fetal pole with the cardiac motion is seen. So it's not at all an incomplete abortion. So the answer here is threatened abortion. So important features of threatened abortion you should remember is The patient will have mild symptoms like vaginal spotting. Os is always closed, right? And the pregnancy will correspond to the gestational age or what she is presenting to you, and the fetus will be live. That is, the cardia will be present, right? And in such cases, you can still revert back the pregnancy with the conservative methods of management. Clear to all of you?
Yes, ma'am.
Right. So going ahead with the next question. Now it's the same clinical scenario. The patient in question 18.5, that is, who had a threatened abortion earlier, presents for repeat sonogram in 2 weeks as shown below. She denies any complaints and pelvic examination is unremarkable. No cardiac motion is noted. What is the correct diagnosis? Missed abortion, ectopic pregnancy, incomplete abortion, threatened abortion. Now this should be an easier one because I've already explained to you what could be the different features. What is the answer? Yes, students?
Missed abortion. Missed abortion. Missed.
Why are you taking such a long time to mention missed abortion? It's so clear, is it not? There is no cardiac activity. Yeah, so there is no cardiac activity. Even here you can see a flat graph coming here. If there were to be a heart rate, if the cardia would be present, then you would have got a nice wavy kind of a, the graph here. Okay, so it's a flat one. You are not able to see any movement. Heart rate or documenting the heart presence of the cardiac activity in just a single image is difficult, is it not? Or cursor on the fetal heart area and showing that the M mode is either showing the waveform and where you are able to measure the heart rate, or not showing the waveform is a flat one, indicating that it's a missed abortion. So always when you're giving a diagnosis of missed abortion in ultrasonography, you need to give this picture both in B mode and M mode. Okay, clear? So it's the same patient. Earlier she had threatened abortion where she had come with bleeding, os closed, cardia was seen at that time. That was at around 8 weeks of pregnancy. Now she's coming to you after 2 weeks. And what is the scenario at this time? After 2 weeks, the pregnancy is there, of course, and she's not having any complaints, no bleeding pervaginally, but on scan, the cardia is absent. So what is the diagnosis you make in such cases? It is a missed abortion. I hope there's no confusion with anybody now. You should be able to identify all these clinical scenarios without any doubt. Clear to all of you? Yes or no?
Yes, ma'am. Yes,
Okay, fine. So we'll go ahead. Now, which of the following chromosomal abnormalities is most common in the setting of first trimester spontaneous abortion? Trisomy 18, 21, tetraploidy, or monosomy X? This also we discussed in the theoretical aspect of the abortions. If anybody can remember, which is the most common cause of, most common? Yes?
Trisomy 18.
It's monosomy actually. It's monosomy. X is the most common abnormality, genetic. No, it is monosomy X. So monosomy X is the most common chromosomal abnormality which is found in the first trimester abortion fetuses post abortion. If they have, confirmed the problem, then it is monosomy X is the most common. Collectively, trisomies 18, 21, and even other trisomies collectively, they are the most common causes. But when you go in for a specific cause as to which is the most common single chromosomal abnormality in abortion, it is actually monosomy X. Remember this, okay? Next one. I think I'll just stop here because the next questions are again based on more, clinical aspects, and we'll discuss in the next class. Until now, if anybody has any doubt or you have any, queries, please let me know so that we can spend some 5 to 10 minutes in discussion. And we can go ahead with the rest of the questions. We have about 30 more questions. We can discuss in the next class in detail again. Yes, students?
Understood, ma'am, everything.
Okay, so any suggestions to be made by you all? You're please free to make so that I can modify the classes according to what you people are looking for.
No, ma'am, this
Yes,
is only
anybody?
okay, ma'am. This is only good, ma'am.
Fine. Right. So what I'm trying to do is, discuss the theoretical aspect as well as the practical scenarios, how we actually practice in, day to day, so that it is more relevant for you. You can understand the theory concepts better, and even the practical based questions you should be able to answer properly. Okay. So nobody has any queries. In that case, we'll end the class here, and hope to see you all in the next week, where again we will discuss more questions on abortion. Right?
Yes, ma'am.
Okay, thank you, madam. Okay, thank you, madam. Students?
So should we call it a day here, students?
Yes, ma'am.
No, if you got any doubts, you should ask the teachers, so that we want to help you only, basically.
Fine. Thank you all again, and have a good evening and good night. We'll meet in the next
9:30
class
there's a
again,
class.
and as intimated, it's going to be on Thursday, 7 p.m. Yes, sir.
Yes, there is a class at 9:30, medicine. Medicine class is at 9:30. Okay. Yes, madam. Okay.